Hi, if you are listening to this presentation, that means we had a snow day. So let's talk about care of patients with non-infectious upper respiratory problem. Okay, as a nursing priority, of course, is to promote oxygenation, making sure that the airway is unobstructed. This is the anatomy of the upper respiratory, which includes the nose and the sinuses, and also the lower portion of the trachea. So this is the area where we're going to see the problems or the diseases, and that's what we're going to look at. First disorder is the fracture of the nose. This is where the bone or cartilage of the nose is displaced, and that displacement can cause air obstruction and also some deformity, and it could be potential source for infection. We look at cerebrospinal fluid. The presence of it may indicate a skull fracture, so we monitor for that as well. Interventions, of course, you had close reduction, which is putting back, just display or replacing back the bone or cartilages, making sure that it's all aligned. And with this, there's really no surgery involved. For rhinoplasty and nasoseptoplasty, of course, are both surgical interventions, and those are completed by ENT, ears, nose, throat doctors. Okay. This is the appearance of a person that just had a rhinoplasty. They have what you call a mustache dressing, and very important that we check to make sure that they are tolerating that have their nose being packed like that, because some people, they might feel like they're being suffocated, so they require a lot of emotional support. Immediate post-operative care after rhinoplasty, of course, you observe for edema and bleeding. Bleeding, especially if they are frequently swallowing, that could indicate that there's a lot of bleeding in the back of the throat. And to check for that, you need to ask them to open their mouth and then observe and see it for yourself. You also need to check their vital signs every 4 hours and make sure that you're changing that drip pad as needed. Also, CSF or cerebrospinal fluid, we check for those for any clear drainage. We ask them to, we used a filter paper of some that's indicated to check for the CSF, and normally a positive would create a halo in the paper. So that's I believe I have a other picture of it here. I'll show you guys shortly. The next thing is nosebleeds, and nosebleed is a very common problem. Some interventions that you do with this, often you just reposition the head, or wait for, hold down the pinch down the nose for a little bit, and sometimes it's resolved. However, there are some situations where posterior nasal bleeding is occurred, or just for some reason it will not stop. We've seen a lot of those cases in emergency room, and as a result, they end up with catheterization, or also nose packing. And sometimes they put like a pack that has a balloon that helps compress the bleeding capillaries. Of course, with this, we have to assess for respiratory distress. The packing is not very comfortable, or the tube is not very comfortable. It feels like you're getting suffocated with that. Humidification, oxygen, bed rest, antibiotics, pain medications are some of the treatments that involve when it comes to this type of interventions. These are some of the interventions that involve in epistaxis. As you can see, there is a packing that they use. They also have a gauze. They use it to again pack. This particular one looks like more like a tampon, but sometimes they even use that. And then of course they have a mustache dressing. This is the tubes that they put in. This is what it looks like when it's not inflated, but this is what it looks like when there's air in it. Can you imagine sticking that up in your nose? That's pretty. It looks pretty big, but that's what they use. Next disorder is the nasal polyps. This is where benign grape-like clusters of mucous membranes and connective tissues are collected in there. There's a large polyp. Some of the large ones can obstruct the nasal airway. So some of the clinical manifestation that you'd see is, of course, there's some obstructed nasal breathing, increased nasal discharges, and there's a change in voice quality because everything is packing in there. Most manage with inhaled steroids, or they do what you call a surgical treatment, polypectomy, as a choice. The next one is cancer of the nose and sinuses. The tumors are rare and then can be benign or malignant. You see this with people that have a frequent exposure to dust from wood, textile, leather, as well as flour, nickel, chromium, mustard gas, radium, all of those chemicals that cause, they're considered carcinogens. Normally they are slow onset. It's the frequent exposure is what the key there. And manifestations resemble sinusitis, but oftentimes they go to the doctor thinking that they have some kind of sinusitis or nasal infection. Local lymph enlargement often occurs also on one side with the tumor mask. They can do surgical removal as one of the main treatments, and also may combine with radiation. So of course they have to watch for any metastasis or anything like that, because with any cancer it can spread. Next is the facial trauma. With this, the priority is of course airway assessment. Some of the things that you would see with fracture or facial fracture like this, they have stridor. They definitely, you'd see some shortness of breath or dyspnea. Anxiety and restlessness, especially if you have something like this, right? They also have hypoxia or hypercarbia, which means they are retaining a lot of CO2. So that's not just because there is a upper respiratory obstruction in there. Decreased oxygen saturation. Sometimes they bluish, cyanotic, because they're not getting enough oxygen, and oftentimes because of the loss of oxygen supply or decrease of it, they lost consciousness. Facial fractures of the maxilla or maxilla fracture are diagnosed according to the Lefort classification, which in this term consists of 3 broad categories based on the level of the fracture. So you have level 1, which is affected the nasoethmoid complex fracture, and of course fracture or level 2 or classification 2, maxillary and nasoethmoid complex fracture are all included. So if you look at this picture, the Lefort one, this is where the nasoethmoid complex fracture, the nasal and the ethmoid bones are affected, and in the Lefort 2, this is where the jaw and the nose and the ethmoid bones are all involved. Okay, so of course this is done by x-ray. You have to see it using x-ray. In here, this one is what you're gonna see as a manifestation for it, and then of course this is for this one. Here's the third kind. This is a combination of 1 and 2 plus the orbital zygoma fracture, also called as craniofacial disjunction. So that means if you look at all of the periorbital, actually the eye socket, not the socket, but the bone that surrounds that protects the eye socket or the eyeball is actually fractured as well. So and these are some of the really bad cases of it. As far as interventions for facial trauma, always airway. Assess airway first. Anticipate the need for any emergency intubation. Oftentimes, if they can't do that, if the trachea is affected, they can